Welcome to this explainer. I am so thrilled you're here because today we're taking a completely neutral, purely data-driven look at one of the absolute most debated topics of our time, universal healthcare. We hear this term literally everywhere, but what does it actually mean? And more importantly, what are the real benefits? And how do these systems truly function in the real world? We're going to break down the evidence, look at the global data, and figure out exactly how these systems operate.
Okay, let's dive into this. Here's the structural journey we're going to take today. First, defining universal healthcare. Second, the economic argument. Third, preventive care and public health. Fourth, international successes and models. And finally, the one-size-fits-all challenge.
All right, starting with Section 1, defining universal healthcare. Let's navigate some of this terminology because healthcare is full of dense jargon that we really need to demystify first.
So there's a really distinct line between two concepts that get confused all the time. Single-payer healthcare simply means that one single government agency acts as the sole insurer. They pay the bills, but the doctors and the hospitals, they remain entirely private. Think of the U.S. Medicare program. That is a classic single-payer model for seniors. Now, on the flip side, socialized medicine means the government doesn't just pay for the care, but they actually own the hospitals and directly employ the doctors. The Veterans Affairs, or VA system right here in the U.S., is a prime example of socialized medicine. To really get a handle on this, it helps to think of universal coverage as the destination, and single-payer as just one possible vehicle to get you there. Universal coverage is the ultimate goal, right? Ensuring that absolutely everyone has access to medical care, completely regardless of their ability to pay. Single-payer is just one specific financial mechanism to achieve that goal. As you'll see, you can actually achieve universal coverage through a bunch of different models, not just by having a single government payer. Grasping this foundational difference is absolutely crucial to understanding the whole global landscape.
Moving on to Section 2, the economic argument. Let's assess the financial impact and look at the massive numbers driving this debate.
So, the crucial point is, based on the data, transitioning to a single-payer system is projected to save the United States a staggering $450 billion annually. That is a 13% reduction in total national healthcare expenditures. But you might be wondering, where exactly do all those systemic savings actually come from?
Well, the savings are generated through three main systemic pathways. First off, we drastically reduce administrative waste by streamlining the incredibly complex billing and insurance procedures that just completely bog down providers right now. Second, a single-payer system leverages what's called monopsony bargaining power. That's just a fancy economics term meaning the government, as the primary buyer, can negotiate significantly lower pharmaceutical prices. And third, there is this really interesting wage substitution dynamic. Because employers wouldn't be purchasing private health benefits anymore, those massive corporate savings could actually be passed right along to employees in the form of higher taxable cash wages.
However, getting to that point requires a pretty massive structural shift. Right now, the U.S. relies much less on public funding compared to its peer nations. Take a look. In the U.S., public funds account for roughly 56% of total health spending. But in stark contrast, the average across other wealthy OECD nations is 73%. So transitioning to universal healthcare requires fundamentally shifting that balance and completely rethinking how we pool our national resources.
All right, Section 3, preventive care and public health. Let's shift our focus from macroeconomics to the human element.
Have you ever put off a minor checkup just because you didn't want to pay the copay? I mean, you definitely aren't alone. According to data highlighted by the American Medical Association, out-of-pocket costs have a profound psychological and practical effect on us. Shifting even a tiny portion of the cost onto patients, we're talking literally as little as $1 to $5, actually causes fewer people to seek out necessary preventive care. For folks on lower or fixed incomes, these minor copays act as a major deterrent. And that causes a dangerous ripple effect where treatable conditions are just ignored until they blow up into full-on emergencies. And, unfortunately, those deterred visits have tragic consequences. The number 22 represents the maternal deaths per 100,000 live births in the United States back in 2022. And for Black women, that number actually soars to 50 deaths per 100,000. When you contrast this against peer countries that have universal coverage, countries that report fewer than 5 maternal deaths per 100,000, it's an incredibly stark reminder of the harsh realities of healthcare access. So the public health benefits of removing these financial barriers are pretty profound. By offering first-dollar coverage, a universal system entirely eliminates the disincentives to seeking preventative care. It allows doctors to manage chronic conditions early on, which keeps patients out of those incredibly expensive emergency rooms. And this does two huge things. It reduces long-term systemic costs, saving roughly 30 cents of every healthcare dollar that's currently lost to missed preventative care, and it objectively decreases income-based health inequality. It's a real game changer.
Let's move to Section 4 and see how this builds. International successes and models. Time to look abroad.
As we mentioned earlier, universal healthcare is definitely not a monolith. There are very different structural forms globally. For instance, the beverage model, which is used in the UK, is heavily government-run, much like our VA system here in the US. Then you have the national health insurance model, seen in places like Canada. That one is publicly financed but privately delivered, very similar to Medicare. And finally, the Bismarck model, found in Germany, utilizes heavily regulated private insurance, which is kind of akin to a vastly expanded version of US employer-sponsored coverage. So there is no single way to do this. And this brilliantly illustrates how a country can transform its healthcare incredibly rapidly. Taiwan is basically the perfect case study here. Back in 1994, they introduced a national health insurance system that was modeled largely on US Medicare. Since then, they've adopted pay-for-performance measures and global budgets to keep quality high and costs low. Today, they boast an absolute staggering 99.9% enrollment rate for all citizens and foreign residents. It is a highly successful, real-world implementation of a single-payer route. But the single-payer route isn't the only option on the table. Look at the Netherlands and Germany. They achieve universal coverage through Bismarck-style hybrid systems that keep financial barriers to a minimum. What's absolutely fascinating here is their intense focus on primary care availability. Get this, in the Netherlands, primary care doctors are actually obligated to provide at least 50 hours of after-hours care annually just to maintain their medical licenses. This aggressively keeps patients out of the ER, and the results speak for themselves. 99% of Dutch respondents report having a regular, consistent healthcare provider.
Which brings us to Section 5, the one-size-fits-all challenge, realities and criticisms.
Now, let's pivot to a strictly neutral analysis and examine some of these structural criticisms. This quote perfectly hits the nail on the head regarding the core critique. A system designed for the average patient with no regard for complexity or diversity ultimately leaves those at the margins behind. The main argument here is that large, diverse countries really struggle to adapt a uniform, one-size-fits-all model to localized or highly individualized health demands. We see this tension super clearly when we compare theoretical promises to on-the-ground realities. The theoretical promise is great, right? Uniform benefits and equal reimbursement rates for everybody. But the reality is that equal funding does not automatically equal physical access to care. In Canada, for instance, there's a severe rural-urban divide. Roughly 8% of their physicians practice in rural areas that house 18% of the population. So despite having uniform financial coverage on paper, rural patients often face intense doctor shortages and much longer wait times for surgeries compared to folks living in urban centers. We also have to look objectively at other systemic vulnerabilities. For one, when the economy dips, these massive government programs often face severe budget freezes. We've seen political fragility in the UK, where austerity measures directly led to massive staffing crises in their National Health Service. Furthermore, formal uniformity can sometimes hide informal inequality. It can unintentionally create a two-tier system where wealthy patients just buy private care out of pocket to skip the long queues. Plus, there's this constant looming concern that lower reimbursement rates will eventually strain and burn out physicians. Finally, let's briefly address the common fear that universal healthcare stifles medical innovation. The data actually suggests a slightly different reality. Universal access and innovation can absolutely coexist. How? Well, if a centralized system correctly harnesses those substantial savings we talked about from reducing administrative waste, it can actively redirect those funds to prioritize high-value precision medicine and nationalized electronic health records. The Dutch system did exactly this. They managed to negotiate and afford highly targeted, super expensive orphan drugs without breaking the bank. And that brings us to our final thought. We've seen the incredible financial savings, $450 billion annually. We've explored the undeniable public health benefits of stripping away cost barriers to preventative care. But we've also looked at the very real logistical complexities and the potential inequities of a uniform one-size-fits-all model. So, I want to leave you with this question. Can a healthcare system truly balance the tremendous macroeconomic efficiency of universal coverage with the necessary flexibility and freedom of individual choice? Thank you so much for joining me on this explainer, and keep asking the big questions.